following is a MyTV 26 production. September of each year is National Prostate Cancer Awareness Month. On September 25, 2017, Modesto's Prostate Cancer Support Group, an affiliate of UsToo International, hosted a panel of 3 doctors representing the 3 major treatment protocols of prostate cancer. It was moderated by a family physician who is a member of UsToo and himself a prostate cancer survivor. This edited version offers an insightful look at the methods, benefits, and challenges of prostate cancer treatment that are particularly useful to the newly diagnosed, but which expands the knowledge of longtime survivors as well.
So, I'm Daryl Wilson. I'm filling in for our illustrious leader, chapter leader, Stephen Dane, who's on vacation this week. I'd like to remind people of our mission with UsToo. Our mission is to help men diagnosed with or treated for prostate cancer and their families lead healthy, productive lives, physically, mentally, and spiritually, by offering fellowship and shared counseling and discussions pertaining to updated medical opinions, options, and positive mental outlook. Tonight we have a very special program that John Snelling has arranged for us. In observance of the National Prostate Cancer Awareness Month. Tonight we have our own John Payne moderating a panel of 3 medical doctors.
I'm temporarily occupying the middle chair, but we'll yield that to Dr. Shiva as soon as he gets here.
I don't have a very loud voice, so can you hear me? Okay. Okay. Thank you very much. Thank you for asking me to come. I appreciate that. My name is Anvita Sinha. I'm a urologist. I'm new to this area. I've only been here for about a year, but I've been a urologist for over 22 years. And so, as you know, prostate cancer is the number two killer of men, right behind lung cancer. The thing with prostate cancer is we do have a tumor marker. As all of you know, it's called PSA, which stands for prostate-specific antigen. And the American Urology Association, or AUA, recommends that PSA be checked starting from age 50 to age 80, and it be done on a yearly basis. And that's the best way to detect prostate cancer. Studies have shown that PSA has improved the detection of cancer. Now, the only other aberration from that is if you have a family history, which means that if you have 1 or more males in your family who have been diagnosed with prostate cancer earlier than 60, that's considered a family history, not over 60, but under 60, or if you're African American, you should start being checked with PSA at age about 40 rather than 50. Anyway, one number helps, but it's more important to have a series of numbers. We look for the PSA rising 0.75 nanograms ml. That's the units used. If it rises more than that in 1 year, that alerts us that there could be prostate cancer. Now, many other things can cause the PSA to be elevated. If you have a colonoscopy within a couple of weeks, if you have a sigmoidoscopy, if you have an infection, if you've been unable to urinate and required a catheter, those things can also make the PSA elevated. So don't let anyone check a PSA if any of those things have happened. So once we're suspicious with the PSA, we don't have any imaging, any x-rays or anything like that that can show us the prostate and show us where the cancer is and where it isn't. We don't have that available. But what we do at this point when we suspect it is we get a prostate biopsy. The way that we do that is normally an office procedure where we use an ultrasound. We can use lidocaine, we can numb it, and we can use blocks to make it more comfortable. So basically, the most uncomfortable part is having the probe in the rectum. The probe is about the size of a man's thumb, and it's placed in the rectum, and through it we can visualize the prostate, and we usually take 6 biopsies on each side, so a total of 12 biopsies. It takes about 6 minutes. It's not painful. It is uncomfortable having something in the rectum for that time period, and of course there's risk of, it's not completely benign process. There are risks of bleeding and infection, so there are things we do to take precaution to have the procedure done. Once we get a tissue diagnosis of prostate cancer, that's when the treatment options are discussed. Now, prostate cancer is graded from 2 to 10. Most people have what's called Gleason score of 5, 6, or 7, which is usually the medium growing cancer. I'm sorry, did someone have a question? Oh, okay. The more aggressive ones are Gleason 8, 9, and 10. I'm going to talk mostly about 5, 6, and 7 because that's what most people have. If the PSA is less than 10 and the Gleason score is 6 or 7, it's really unlikely that it has spread anywhere else. Now, prostate cancer usually goes to the lymph nodes or the bones first. So if we have suspicion that it has, then we check a bone scan and a CAT scan to see if there's any evidence of metastases. Once it's confirmed that it's just in the prostate, that's when we have the best chance of curing it. Now, because prostate cancer tends to be, in general, a slower growing cancer, we tailor the treatment according to the patient. So the younger and the longer life expectancy, the healthier a patient is, the more aggressive we want to be. Now, the 2 proven ways of treating prostate cancer are surgery and radiation. There are other methods too. There's something called cryotherapy where the prostate is frozen. That's also an alternative, but usually we save that for people who have failed radiation therapy. But there's other methods too, but they haven't been around long enough to really have good data as to comparing them to radiation therapy or surgery. Now, as far as surgery goes, generally we want to reserve that for men who have 20 years or more life expectancy. And the reason is because there are risks to surgery. There's the usual bleeding and infection, but the surgery requires about 3 to 4 hours, and with that, anesthesia for that much time. So if someone has other, what we call comorbidities or other medical problems, such as heart disease or lung disease, and we don't think that they will be able to survive the surgery, or then we don't recommend it to them. What the surgery involves it's called robotics-assisted radical prostatectomy, and all that means is that we do it laparoscopically. So laparoscopically means rather than making one large incision, previously we had to make an incision about that big, basically from the belly button down to the pubic bone. Traditionally, patients stayed in the hospital for about a week, or we had it down to about 3 days at one point. But with the robotics assisted, we make several small incisions, which are not as painful. One incision is a little bigger because we need to get the prostate out. But the others are smaller, and so we make those incisions and we put the instruments through them. And we also have a camera. Now, the camera magnifies, and so rather than seeing things in real life, we see it on a screen about this big, and it's magnified about 5 to 10 times. So with that, and also the instruments are much smaller, so they're less than a centimeter in size. And so laparoscopically, when we worked, the instruments were this long, and we had control of them here. So you can imagine trying to do surgery this far away, not as precise. So there was a big learning curve, and a lot of people knew how to do it open, so they did. Well, with the robotics, we have much better, robotics assistance, we have much better control. We actually have the same control as in our fingertips. We actually use our fingertips with those small instruments to do the surgery. So everything's magnified, the surgery is more precise, and we are able to do it with less blood loss. People usually stay overnight, so they're not staying as long. They need less pain control. So that's why the trend's been to performing robotics-assisted prostatectomy. Now, the robot is also very expensive. Not every hospital has that. You know, not everyone's been trained with that. So, but it's slowly progressing as that being the better route to go. After the procedure, you have to have a catheter in the bladder because basically, you know, there's the bladder and the urethra, and the middle portion is removed, so the ends are sutured back together, and that takes some time to heal. So people have to have men have to have a Foley catheter, and that only stays in for about 1 to 3 weeks. Once it's healed, then it can be removed. Now, as far as, you know, the normal risks that I discussed, you know, heart attack, stroke, you know, things like that during the surgery that men may see is something called stress incontinence. Stress incontinence is when people leak with coughing, sneezing. It's something women have more than men usually, but after this kind of surgery, men can have it. Usually that's something that improves with time. Within a year, it's usually gone, and if it's there, it's only a few drops. But that's one thing to consider. The other thing is sometimes after the surgery, anytime anything heals, it can heal with a scar. So there's also a possibility there can be a scar there, and that could be immediately after, or it could be years in the future. So another thing to keep an eye on. And the other thing is, I'm sure that everyone's concerned about, is erectile dysfunction, problems having erections afterwards. Now, the reason that that's an issue is because the nerves that are responsible for erections are just next to the prostate. They're about 4 and 5 o'clock position and 7 and 8 o'clock position right next to the prostate. So whenever we do anything to the prostate, including radiation therapy, it can affect that. So surgery, of course, is more traumatic because we actually have to peel the prostate off the nerves, basically. Nerve-sparing surgery, I noticed that was one of the questions. That is something that we can do, but it's not 100%. And the limitation are that, you know, if the cancer is in both areas, both of the sides are involved, and there's extensive cancer, the goal with the surgery is to cure the cancer. It's not as much to address the erectile dysfunction. So sometimes, even in the best of hands, it's just not possible. There are therapies, and that's a question later on, so I'll address it at that time.
I'd like to ask Dr. J.D. Naburi now tell us about radiation oncology and its treatments for prostate cancer.
So my name is J.D. Naburi. I did my high school out in Fremont, did my undergraduate out in San Diego, and I've been going through medical school and training for the last decade or so. So next slide. So the aims of my talk are just to go over what radiation is. I'm going to briefly go over the different types of radiation. It seems like every time you turn a TV on, there's somebody advertising a new mode of radiation. Hopefully I'll bring some clarity to that. I'll go over some possible side effects of radiation, and more for your own personal care. I'll try to give you some tips for how to take care of yourself during radiation and what follow-up entails for patients that ultimately undergo radiation. Next slide. So what is radiation therapy? It's a type of cancer treatment that stops cancer cells from growing. More specifically, it causes damage to the DNA similar to many chemotherapeutic agents. Radiation can kill the cancer cells. It can stop the cancer cells from growing without killing them. And in patients with metastatic prostate cancer or prostate cancer that's causing pain, it can reduce some of the symptoms that the cancer is causing. Next slide, please. So one way to think about radiation, and I tell all my patients this, is think of it like a flashlight. All of the effects of the radiation only happen where the flashlight is aimed at. So in men with prostate cancer, we're going to be pointing it at your prostate, and all the side effects are going to be limited to the prostate and the areas surrounding the prostate. And the reason radiation works is, as you can see kind of in this picture, not really that well, is that radiation has to go through the skin, it has to go through normal tissue, and then it hits the prostate cancer cells. Now the prostate cancer cells die because they're not normal cells. But your normal cells and the rest of the tissue that's normal is able to heal itself pretty well. And sometimes when it can't heal itself, that's when you start seeing the side effects. Next slide. So the different types of radiation in prostate cancer, and I'll go through each of these briefly. There's external beam, which is what most men receive. That includes X-rays, protons, and if you go to Japan, they have carbon ion. I think Stanford's going to get it in a few years. There's internal, which is prostate seeds, and the newest form is intravenous or Xofigo. And I'll go into, that's only for a very specific set of patients. Next slide. So the first type of radiation is external beam, and this is what the majority of men that get radiation end up getting. And so it's similar to the flashlight, like you can see in the upper right. It's this giant machine, maybe half the size of this room, and you go in there and you lay down on the table, and then the machine kind of rotates around you, and the table that you're on sometimes rotates as well. We call that the couch. You can see kind of in the bottom left there. And then, so the three most common types of machines that are out there are on the bottom. The one on the left is what we call a Linac. That's what we have at our offices. That's what, as far as I know, everyone in the Valley has. Tomotherapy is another very similar machine. In that machine, the patients sit on the table and they get moved on the table as the treatment's going a little bit more. And then the last one is called a CyberKnife. That company is based out of, I think, Palo Alto, somewhere in the Bay Area. But regardless of which three of these machines you use, or proton or carbon ion, they all do the same thing. They work like a flashlight, and they are aimed at the prostate, and they kill the prostate cancer cells. Next slide. I think you missed one. So this is what I do as a radiation oncologist. We look at these plans, and each of these different colors represents a different level of radiation dose. And as a radiation oncologist, we determine if this is safe to give to a patient. And as you can see, these are excellent plans in that the radiation really only goes to the prostate, or high levels of radiation really only goes to the prostate. And it doesn't, in the bottom right, you can see it doesn't really affect the bladder, it doesn't really affect the rectum, and it's centered right on the prostate. So this is the typical plan that we see, I think, in modern day prostate cancer treatment if the prostate cancer is localized. Next slide, please. And so you'll see a lot of advertisements for proton therapy, and this is what the proton therapy plans look like. And you can see that they'll only have 1 or 2 sites of entry, and their dose will be a little bit more limited. Whether or not this actually achieves any meaningful clinical benefit to patients, I think is still being studied. And also, more importantly, I don't know if the proton therapy machines are quite as accurate as the machines you just saw. Next slide, please. So the process that most patients will undergo when getting radiation is you'll initially see the radiation oncologist for consultation, determine what type of radiation you're supposed to get, whether you're a good candidate for radiation, whether surgery might be a better option for you, make sure all of your workup is done. And then we get a CT simulation scan, and this is the scan that we use to draw your radiation plan. And then I go through it with my team and make sure that it's safe to give you, that we're not giving too much dose to the surrounding organs like the rectum and the bladder. And then you come in for your daily treatment. And now, typically, prostate cancer patients that are getting external beam radiation will get anywhere from 5 to 45 treatments. So, and that's Monday through Friday, so 1 week through 9 weeks. And then once a week, you meet with your radiation oncologist and you go over any possible side effects that you're having. And after your treatment's done, you follow up with us, you follow up with your urologist, with your medical oncologist if you need to, and we make sure that we manage the toxicity and assess you for any signs of the cancer coming back. Next slide, please. The next type is internal or prostate seed radiation. It's also known as brachytherapy, the fancy term for it.
Okay.
Could I get the next slide? So this is more similar to surgery. Oftentimes it's done with a urologist in the room, and a radiation oncologist and a urologist work together in the operating room to deliver this. So the way this works, as you can see kind of on the left side of the screen, we use an ultrasound inserted into the rectum to help us visualize the prostate, and then we insert needles through the perineum into the prostate. And doing that, we're able to put seeds into the prostate, like you can see in the bottom right. So this is a permanent implant. There's also HDR brachytherapy, which is not permanent, but requires more operations. You sometimes have to get 2 or 4 trips to the operating room. And there's some advantages and disadvantages, but you can see the typical plan or in the upper right for what a brachytherapy looks like. The radiation is very localized. It's a very high dose to the prostate and minimal to the surrounding tissue. Next slide. So for the internal radiation or the brachytherapy, it requires surgery, it requires anesthesia, there's a risk for infection, it can cause more pain. It's not necessarily for all men. You have to fit into a specific box. You have to meet some criteria to do it. You have to be a candidate for surgery. You have to be able to undergo anesthesia. But the benefits of it include that it can be done in one treatment, and like I said before, it's very localized. You don't risk any radiation going to the rectum or to the bladder. But there are some other side effects that are associated with it. Next slide. And lastly, I just wanted to briefly touch on Xofigo, and we can go to the next slide. So this is an intravenous form of radiation. It's only for a very select group of patients with, I think you skipped one slide, for a select group of patients with metastatic prostate cancer, only to the bone. And this is another radionucleotide that kills cells, only in prostate cancer cells, only in the bone. And next slide. So possible side effects of radiation: you can have some fatigue, you can have some skin changes, loose stool, you can have some blood in your stool, you can have some increased problems urinating. Many of my patients come with already an underlying level of problems, but radiation can certainly make it worse during. And then you can have pain and bleeding associated with the internal radiation. So the side effects you see on the left are short-term or acute side effects, and these are what happen during radiation and the weeks immediately after radiation. And they almost all get better to a large extent, but some can continue on. And when they continue on, that's when we call them long-term side effects. And apart from all of the short-term ones that continue on, you can also start to experience sexual dysfunction. And it typically gets worse over time, or you see it in more patients over time, as opposed to surgery where you might see it more immediately after surgery. And so sexual dysfunction is something I think that's common to both of our procedures, but in radiation's case, it typically builds up or occurs with increasing frequency till about 2 years. And then we don't really see in patients that much, or occurring newly in patients after that. Next slide. So how severe are the side effects? So it varies from person to person. Each patient is different. Most patients are able to work, drive, cook, clean, exercise, continue their activities of regular living during external beam radiation. And the side effects of external beam radiation typically build up more towards the end of therapy. Most patients that get it for the first 2 weeks don't experience too many side effects, and then towards the end of the 7th or 8th week, it kind of builds up a little bit more. Fatigue is typical during radiation. It's probably the one side effect that I'd say the majority of patients get. And with the exception of sexual dysfunction, most of the side effects that I talked about usually disappear in 1 to 2 months in most patients. Again, each patient is different. Next slide, please. Radiation can be used by itself or with other types of therapy. It depends on the stage. That includes using different types of radiation together, such as using the internal and the external. And oftentimes we use it with hormone therapy for intermediate and high-risk patients. The one thing I will say about combining different modalities of therapy is oftentimes the side effects are worse when you combine more than one. That includes surgery, ADT, and radiation, as well as chemotherapy. Next slide, please. So what can you do to help yourself during treatment? I encourage this of patients with all types of cancers. Talk to your doctors, talk to your medical providers. We are all here to help. Let us know about all medications you're taking. I know a lot of times, and especially my patients, we don't necessarily go through all of the vitamins and the nutritional supplements that you guys are taking, but some of them can have medical effects that we need to know about. Be thorough in your history. Let us know of all of your problems. Get enough rest and sleep. Eat and drink consistently, and wherever you guys get your radiation, they will go through this, or they probably have gone through it with you, with most of you. Be regular in your eating and drinking in terms of food, because that affects how the radiation sets up daily. Mild exercise, and smoke. Don't smoke. None of you should be smoking at all, but especially during radiation, because it can have worse outcomes. And I think that's it. Just one thing about follow-up, it's just how we assess for the disease coming back. But that's about it.
We have Dr. David Sheba from oncology. Oncology most often gets involved with prostate cancer either early in the process, where you're sort of trying to decide what to do, and you have an unbiased person who can help you decide between radiation and surgery. But they're also often involved after both the other forms have done their best, and it wasn't enough. So Dr. Sheba, would you give us a little bit of oncology overview?
So basically, let's just start talking a little bit at the very beginning. We've heard the term already called androgen deprivation therapy, or ADT. And the purpose of it, and this is what you usually start with, and there are different ways of obtaining ADT, or androgen deprivation therapy. The whole goal of it is to decrease testosterone levels. So the female in the room, if you happen to have any experience with breast cancer, one of the treatments that we commonly will use in breast cancer is treatment to decrease the estrogen, and because we say that estrogen acts like food for the cancer. Well, in the male, the testosterone is like the female estrogen. And that the purpose of all of this therapy, at least at the beginning until we get into more systemic kind of therapy, which we'll talk about, is to decrease the levels of the testosterone. So basically we're going to starve the prostate cancer so that it doesn't have the food it needs in order to grow and divide and spread. And that's the whole purpose of ADT therapy. And the purpose is to get the testosterone levels low, and that's really important. And it's something that before we ever make the decision that your cancer is no longer sensitive to hormone manipulation, we need to test that level of testosterone. Even though you take the same Casodex and get the same Lupron injections, every person is different. And you could be taking it and not getting what we call decreased levels of testosterone. And usually it's about a concentration of less than 50 nanograms per DL. As far as response rate, by this initial therapy, and we'll go over each of the different ways of obtaining it, normalization of PSA occurs in a very high frequency, probably greater than 90% of the time. The unfortunate thing is cancer is pretty smart, and pretty soon it figures out how to get around your particular blockage, your particular treatment. And that's when it becomes, the response rates decrease, and the average time is about 1.5 to 2 years that you'll get from that initial blockage of the testosterone. After that, the PSA starts to go up. We may or may not see development of metastatic disease, but for all practical purposes, the cancer is starting to overcome what we've done to try to starve it. It's finding alternative ways in order to get what it needs in order to grow and to spread. So how is ADT done? I mean, there are several ways. One of the easiest way, so to speak, is surgical orchiectomy or castration. That accomplishes the same as medical castration, but the difference is with medical castration you have to basically receive an injection, usually every 3 months. If you get Lupron, or if you get Zoladex, or if you're at the VA, it's called Eligard, is what the VA uses. These are usually given to you once every 3 months, so you have to come in and get a shot. Hopefully you don't have a large out-of-pocket copay. Those shots are about $3,000 each every 3 months, unfortunately. But they accomplish the same thing as the surgical procedure. But with the surgery, you're done over with. You never have to have a shot. Then there's also a different kind of agonist, or antagonist, which we rarely use. It's called Degarlix. It's a GnRH antagonist. The advantage of this agent, although it never seems to have taken hold here in the U.S., is that within 3 days you've already achieved castrate level testosterone levels. With the Lupron, the Zoladex, it takes anywhere from 2 to 4 weeks in order to obtain those levels, so it is a little bit slower. But they all work the same, and basically they're trying to lower those levels of testosterone to a level on which the prostate cancer cannot tolerate, and therefore the cancer cells die. Then what else can we do? We can add other agents to that. So usually we start with one of the either Lupron or Zoladex in most people's cases, and the PSA will come down, and then after a while that PSA will start to go up. And then we tend to go looking. We want to know where it's coming from. And as was said earlier, the most common places that prostate cancer goes is to the lymph nodes or to the bone. And you may not have symptoms, and it could still be there, and that PSA will gradually go up. Going to vital organs, such as the liver or to the lung, is pretty uncommon. In fact, if it goes to the brain, it's almost a reportable event, because it just doesn't happen very often. And thank goodness, because then we don't have to deal with problems with liver not functioning or problems with a lot of shortness of breath, because it's not going into the lungs themselves. So after the PSA starts to climb, and we have deemed that the Lupron or Zoladex isn't working by itself, we then add what we call anti-androgens. So instead of working on the signal, which then stimulates the body to make testosterone, these anti-estrogens or androgens are like hands, and they basically will block that receptor or that hand for testosterone, and they compete with the testosterone that's in your body. And some people say, well, you know, I've had my testicles removed, why should I still be making testosterone? It's like a female with breast cancer. Even though they have their ovaries removed or they've gone through menopause, they're still making estrogen. And that's because of these little glands that sit above the kidneys called adrenal glands, in which cholesterol is converted into either testosterone or into estrogen. So you still have a source of making it even if you've undergone surgical castration. So then there's a whole series of these drugs. The most commonly used one I think today is Casodex, and that's probably because of the profile. Also, you only have to take it once a day. There are several others of these. Ulixin, I remember when I first started training, we actually used Ulixin. The problem is it caused severe diarrhea, so nobody really liked to take that very often. And then there's one that's less commonly used called Nilandrone, but they all work the same. They compete for the testosterone, basically, receptor, and they block it so that testosterone can't get there. What kind of response rate? Probably about 30 to 50% of patients will have a decrease in their PSA after we add this to the Lupron and Zoladex. One of the things we don't do is we continue the Lupron and Zoladex. Even though your PSA went up while you were on it, we still continue that. In fact, a lot of times we'll continue it even when you proceed to other therapies, and we'll talk about some of the additional therapies or newer therapies, such as Zytiga and some of these newer agents. We actually continue the Lupron throughout this whole process because it's been shown by continuing it, it actually works better than if you just give Zytiga by itself or Zytiga prednisone by itself. That still maintaining that Lupron, we're still decreasing the levels of testosterone, and it still has a benefit even though your cancer may have progressed while on Lupron itself. Then there's what we call secondary hormone manipulations. We used to use them a lot more, and that was because we had very little to give as far as other treatment. You know, chemotherapy, when I first arrived about 27 years ago, I can remember having a patient and we were giving him chemotherapy. All we had was IV Cytoxan. And he would come in and get IV Cytoxan during the night so he would be able to open up his shop in the morning. And he never missed a day of work. But that was really all that we had. So we used to use other things like ketoconazole, and we combine it with another steroid, hydrocortisone, DES, something that actually works pretty good and is very cheap. The problem is it can cause blood clots. The other problem is you can't bind it. It's very difficult to bind, even though it's such a cheap drug, and will work even after some of the newer agents such as the Casodex or the Ulixin have stopped working. And then finally, we, or at least I tend to, still do what we call a withdrawal. So let's say you've been on Lupron and Zoladex and you've been on your Casodex, and all of a sudden the PSA starts to go up. So one of the things we'll commonly do is stop the Casodex or stop the Ulixin or whatever else you're on with the Lupron or Zoladex. And in about 20 or 30% of cases, that PSA will start to come down again when you do this withdrawal. Unfortunately, it's a very short duration. And so that down the line fairly soon, you're going to now have to think of other types of treatment. So then we get to a point in which we call castration-resistant prostate cancer, or CRPC. They're the initials you commonly have seen. And that's when, despite all of these hormone manipulations, the PSA starts to go up. Sometimes you get what they call biochemical-only disease, meaning that the PSA goes up, we do our CAT scans, we do our bone scans, we can't find any disease anywhere else. So the PSA is continuing to rise, but there isn't anything that we can detect. You can either have a slow doubling of the PSA or you can have a rapid doubling of the PSA. And the reason that's important is it's how frequently that we'll then evaluate with the CAT scans and the bone scans, and also digital rectal exam looking for a local recurrence. With the more rapid one, we usually check every 3 to 6 months. If it's a slowly rising PSA, we usually go every 6 to 12 months. But basically what we're looking for is sometimes the disease just comes back, either locally, where the prostate was before you had radiation or you've had surgery, or it may come back in one of the lymph nodes that haven't received radiation before or wasn't removed during any kind of surgical procedure. And the reason of doing that is there are a small group of patients who, if we're very diligent in this so-called active surveillance, that if we find it localized, that we can then quote-unquote salvage and potentially cure again patients who have recurred and their PSA is going up. And we can do that sometimes with radiation, or if they've had radiation before, sometimes surgeons can go in and do what we call salvage surgery in order to give us a chance that we're going to cure the disease. Unfortunately, the majority of the patients, that's not going to happen. You can still radiate and eventually it's going to show up elsewhere. Again, primarily in the bone is where we commonly see it. And the common presenting symptom is that of bone pain. And as I always tell patients, we're all getting older. We wake up in the morning and we'll have an ache in one knee or one hip, and then the next day it may be somewhere else. That's not what we're talking about. As I always tell patients, you should be able to say it hurts here, and every day it's getting worse. That's the kind of bone pain we're looking at. The other little pearl is cancer tends not to go from the elbows out or from the knees downward. So if that's where you're having your pain, the chances are it's probably not due to cancer. Except in 27 years, I had one case. A head and neck cancer patient who underwent an amputation of a toe for pain that had head and neck cancer to a toe. I mean, that's reportable. We just don't see that very often. But as a rule, all your pain should be elbows more toward the trunk, from the knees upward, and it doesn't involve the joints, because the joints don't get cancer within the joints that have spread from prostate cancer.
I'm 56. I've just recently diagnosed with prostate cancer. I have like a 4.5 PSA. And so I suppose I'm on an active surveillance, aggressive surveillance, as my doctor would say. And he's suggesting that in December that I go in for an MRI, and then after that, another biopsy. So I have a Gleason score of 6. I've already had one biopsy, and I have a 4.5 PSA. And my PSA has climbed in the last 3 years.
How fast?
In the last 3 years, 2 to 4. And then, so it started with just a physical, and then the PSA was high, so they had to have a biopsy. So my question is like, it seems like it's Russian roulette. When do you take action on this? You know, how high does your PSA get? Or another big question is, do I do the MRI in December? Why the biopsy again after I've already had it once after the MRI?
Those are questions you need to discuss. Those are questions you need to discuss with your doctor.
Really?
Yeah. Ask specifically those questions.
One of the quality of life things that happens when you do get a PSA that is in that borderline range, and then a biopsy with a Gleason 6, is that you now have anxiety added to all your other problems. And the anxiety is a really tough thing for patients, because doing nothing sounds like the wrong thing. It's always the wrong thing to do nothing, right? Not necessarily.
What they're looking for is to see if it has advanced. So I don't know what your Gleason score is, but that's what I'm thinking, what they're doing. 6 to begin with, so the biopsy is to look to see, the MRI is to see if they can see it, and then the biopsy is to see if it's advanced to a 7 or an 8. But those questions you need to discuss with your doctor.
Sure. And
We're constantly bombarded in different media by everything from superfoods to testosterone boosting medications or pills or whatever. And once you've had your prostate removed, and is there any benefit to taking testosterone, perhaps even for erectile dysfunction after that, or would it be a detriment to your system? I'm constantly amazed by how much they're trying to sell testosterone boosting products when apparently a big cause of prostate cancer appears to be because of testosterone.
Okay, first of all,
That's about 3 questions, I think.
and it's a complicated question, but first of all, testosterone doesn't cause cancer. But if you have prostate cancer, it's like adding fuel to it. So, but it doesn't cause it, okay? Secondly, as far as testosterone supplementation, I can only speak of the medical testosterone. I don't know any about the supplements, because I'll tell you what, when we started out with testosterone supplements, first we had oral pills. What we found was they were ineffective and they caused liver damage. So because of that, no one uses testosterone pills. We have other ways of giving it. We have gels, injections, we have other modalities, but no one uses testosterone pills. So I don't know what those supplements have. As far as testosterone supplementation, it doesn't really help with erections. It helps more with libido, with sex drive. And we are very careful to give testosterone injections or gel, because it also increases the risk of heart attack and stroke. Basically, it makes the blood thicker. So we only give it for the right reasons, which is usually if someone has, well, not libido so much, but that's one of the components, but if they're very tired, depressed, if they have no energy, and on top of that, we find that they have low testosterone. We discuss the risks that are involved with that, and then those people need very careful monitoring with blood tests every 6 months. No matter how we give testosterone, it can affect the liver and it can affect the blood count. So we usually monitor that every 6 months.
Thank you very much.
Thank you.
I'd like to make sure that we thank John, our moderator, and John Snelling, who arranged all this.
Yay.
On behalf of all prostate cancer survivors and their loved ones, UsToo thanks panel moderator and one of our own, John Payne, MD, and wish him the best of health and happiness as he embarks on his well-earned retirement. And to our distinguished panel, Anvita Sinha, urologist, Sutter Gould Memorial Foundation, Jaydeep Niburi, MD, radiation oncology, 21st Century Oncology, and David A. Sheba, MD, medical oncologist and hematologist, Sutter Gould Medical Foundation. Your generous, caring spirits are as healing as your depth of knowledge and finely honed skills. We also wish to acknowledge MyTV 26, Modesto's public access channel 26, for its excellent support in taping and editing this presentation. Janeiro, Freeda, you are an amazing talent. Lynette Scott, your energetic accommodation of our needs helped us to say yes to the idea of a video, and your passionate pursuit of its creation has been unflagging. The fine work of Channel 26 extends the reach of UsToo's mission through the wisdom of these wonderful doctors. To the Sutter Health System of Northern California through its Memorial Medical Center and the Gould Medical Foundation. To 21st Century Oncology of California through its Modesto Treatment Center. To our parent organization, UsToo International, whose mission is to provide hope and improve the lives of those affected by prostate cancer through support, education, and advocacy awareness. Our local chapter is one of over 200 affiliates in America and abroad. We meet every month except December on fourth Mondays at Sutter Memorial's Health Education and Conference Center in McHenry Village. Learn more about us by visiting the Mano Community Health Library at the Conference Center or by calling 209-523-0732.